That if you have patients who
this meeting is being recorded
may benefit from such procedures, Moi Kibaki Hospital will be glad to support them. So we welcome you all. We just need to have some housekeeping measures. Kindly, if you have questions, you can type them at the Q&A section. So we'll be able to answer them as once the presentation is over. And we'll be able to discuss with you further in details on the areas that you need clarification on. So allow us to start in a moment.
Okay. Good afternoon. I'm sorry for the delay. I was held up in ICU. My name is Dr. Nguchu. We're going to now discuss about hypertension, the basics. So the first thing I needed you to see is how to measure blood pressure. I assume that I'm talking to clinical healthcare workers, and therefore most of you know what hypertension is. However, it's important for you to first know how to measure a patient's blood pressure, because that's the basis upon which you're going to make the diagnosis and decide on your plan of treatment. Main issues I want you to notice is, number one, the patient should be sitting comfortably with their feet flat on the floor. They should not be talking. They should be silent. Their back should be well supported. Identify whether or not your patient is in pain, because if they're in pain, the blood pressure tends to go up. You make sure that you pick a cuff that fits the arm size of that particular patient. So smaller patients, you pick the smaller cuffs. Big patients, obese patients, pick a bigger cuff. So it would be preferable if we had different sized cuffs so that we can actually individualize the measurements. We make sure the arm is bare. I say that because I sometimes see patients being measured blood pressure while their shirt is still on top of the shirt or the blouse. You find a way of exposing that so that you can measure. And you make sure it's at mid-arm level. The room should be quiet, it should be comfortable. The patient should not have smoked or taken coffee or caffeine or exercise within the last 30 minutes. Effectively, what that means is if your patient has just walked in, give them about 15 or 30 minutes to rest before you check that blood pressure. The patient should not be uncomfortable with a full bladder. And then the best thing is to take 3 measurements at 1 minute intervals. So what you do is that you take a fast blood pressure, you wait, you repeat again, you wait after 1 minute, you repeat again. Then you take the average of the last 2 measurements. Now, how do we classify blood pressure? It's essentially divided into normal, which is actually less than 130/85. The high normal is 130 to 139 with a diastolic BP of less than 89. Grade 1 hypertension is between 140 to 160 and a diastolic of 90 to 100. And grade 2 hypertension are those patients who are above 160 and diastolic above 100. Now, in some patients, you might find, for example, the systolic is, say, 158, but the diastolic blood pressure is 102. So that patient will be classified as a grade 2 hypertensive. So you put the patient based on the higher measurement you find, whether it's diastolic or systolic. So if your patient has a blood pressure of systolic 180, but the diastolic pressure is 50, that patient is still a grade 2 hypertensive patient because the higher measurement, the systolic is above 180. So in most cases, we take office blood pressure measurements, but it's important for us to also check home-based measurements. The ideal level for home-based measurements is as indicated there. And what we do for home-based measurements is a patient comes into the hospital, you check the blood pressure, you notice the blood pressure is elevated. Maybe this is the first time you're checking, and this is the first time the patient tells you, no, I've never had high blood pressure. This is my first measurement. So ideally, what we do is this gives you just a plan. If you check and the blood pressure is normal, that is it's below 130/85, these are patients whom you can see every so often, even within 3 years, if they have no risk factors. But if the patient is diabetic or has hypothyroidism or has any other clinical condition, you should see them sooner. For patients whose blood pressures are ranging between 130 to 160 systolics, or diastolic is between 85 and 100, these are patients whom you send for out-of-office blood pressure measurement. What this means is a patient you may first see, and let's say their blood pressure is 159/90, and this is the first measurement, they're not on treatment. You can tell that patient, you go home, we'll check your blood pressure with a machine either at home or at a nearby facility. And then they keep a record of that, and the patient comes back within a week with those measurements so that you can make a judgment. Ideally, we should do what we call an ambulatory BP monitor. Those ones are usually available with cardiologists. You can actually refer the patient here to Kibaki Hospital. We can do for them that. For measurements above 160/100, we need to confirm within days or weeks. How do we evaluate these patients? The main things we're looking for is target organ damage. So the things I need you to remember in these patients is you're looking at brain, features of stroke, eyes, visual loss, heart, features of heart failure or heart attack, so chest pain, difficulty breathing, fatigue, leg swelling, kidney disease. So we are looking at whether or not these patients wake up at night to pass urine, nocturia, which is one of the earliest signs of renal disease or edema. Find out from the patient if they have any other risk factors, family history of heart disease, where we are talking about father, mother, and immediate siblings. You're looking for diabetes, high blood pressure, cholesterol, sudden death in the family. Look for other risk factors such as smoking with the patient. Ask the patient if they snore, because snoring is an indication of sleep apnea. And then you also examine the patient for obesity. So check the weight circumference, check the patient's weight. And we also look for secondary causes of hypertension. The commonest causes now that we look for is renal artery stenosis, which when you examine on the abdomen, you should hear some bruit. A bruit sounds like a woo, woo sound, which you'll hear in the abdomen, just near the epigastrium. Basic tests for all patients, we should check hemogram, UECs, blood sugar, lipid profile, urinalysis, a 12-lead ECG, and a baseline fundoscopy. I put the fundoscopy in red because we all forget to ever check that. Please make sure you check for that. What are the additional tests you can do? And these ones you'd refer to a consultant. But I need you to remember these first ones. Do a hemogram, UECs, urinalysis, blood sugar, lipid profile, 12-lead ECG, and a fundoscopy on all these patients. Additional tests we should do, thyroid function tests to rule out thyroid disease because that's a secondary cause of hypertension. Renal artery Doppler ultrasound to rule out renal artery stenosis, 24-hour metanephrines for pheochromocytoma, free cortisol for Cushing's, CT aortogram for coarctation of the aorta, and a sleep study for obstructive sleep apnea. But before you guys start thinking of these ones, I need you to remember this. If you examine the patient properly and you check them from head to toe, you should be able to pick up some of these before you do the tests. So like, for example, for the thyroid, you look for skin dryness, sluggish patients, patients who appear hyperactive, they have protuberant eyes. Those ones already suggest some abdominal thyroid. Look for a goiter. For patients in whom you're suspecting coarctation of the aorta, all you have to do is just check if you have a dorsalis pedis pulse. So when you check the patient's radial pulse, just check if you can also feel a dorsalis pedis pulse. If there's none, proceed on to now look very seriously for coarctation of the aorta. And for that one, you just check for a pulse on both hands. So if you can get a radial pulse on the right side, but you're not getting one on the left side, that is coarctation of the aorta. For pheochromocytoma, usually these patients will tell you, I'm fine, and then suddenly I get palpitations, I start sweating, I feel anxious, my blood pressure shoots up. That's a patient you screen for pheochromocytoma. Sawa. There are some drugs that can induce hypertension. I'm pointing on the main ones. NSAIDs, which we give right, left, center. Please avoid those ones because those ones actually cause hypertension in patients and complicate other diseases like renal disease and heart disease. In women, all women, please find out what contraceptives they are using. Hormonal contraceptives, not just the oral one, but oral, the injectable, the 3-month injection, and the, what do they call it? The Norplant. Those ones can actually cause hypertension. There's a very dangerous pill called and I'm looking at the females in this room. It's a herbal pill that they give once a month. That one, please avoid it at all costs. It's causing hypertension and a lot of problems. Oh, it's called Sophia. Please avoid Sophia at all costs. Please find out if your patients are using this drug. They're told it's a monthly herbal contraceptive pill. It is not. It's a combined estrogen pill at very high doses. Antidepressants, specifically, we are talking about the serotonin reuptake inhibitors and the benzodiazepines. Those ones can actually increase your blood pressure. Paracetamol can actually cause elevated blood pressure in patients who use it daily. So find out if your patient has a headache and they're continuously swallowing paracetamol. That is Panadol. Be very careful, because that one can also cause hypertension. Other medications, of course, steroids, which are given for asthma. Please stop giving steroids for asthma. Let's treat asthma patients properly. So investigate whether or not your patients are buying steroids over the counter. Find out if they are using pseudoephedrine in cough syrups, because that one also causes a lot of hypertension. And actually, you find that the patients who are given the cough syrups are also the same patients on steroids. So most of the time, you're giving them a double dose of hypertension. And then, of course, herbal drugs and alcohol. So what do we do for patients whom we diagnose with grade 1 hypertension? Grade 1 hypertension, remember, the ones whose blood pressure is above 140, but the systolic is below 160, with a diastolic of 90 to 99. These ones, you start them on lifestyle intervention. So that means exercise, weight management, low salt diet. For those who eat KFC, please stop eating KFC and stop eating pizza and stop eating those fast foods. I'm talking to the audience in the room. And then for those patients who are high risk, those are patients in whom you diagnose that they have kidney disease. So like you've done the UCs and you find that these patients' kidneys are not good, or the ECG is abnormal, or the patient is diabetic. Those patients, you should start them on treatment immediately. For others, you can actually give them room. You check first if lifestyle will work. You can also just go and do home monitoring of blood pressure. And if the blood pressures are elevated, you start them on treatment. But there's a caveat to this. That patient whom you're sure will disappear and not come back, sincerely start that patient on treatment, because these are the patients who come to us in complications. If they tell you they're going to church to pray, tell them come back in a week's time, we see whether or not the pressure has resolved. Grade 2 hypertension, that one is not debatable. Start the patient immediately on medication and lifestyle. What are the lifestyle I was saying? Stop smoking, regular exercise, lose weight, salt reduction, healthy diet and drinks, lower alcohol intake. When we say lower alcohol intake, would be preferable 0, but sometimes patients ask you, give me leeway. So tell them 1 unit. So for example, a beer a day. But do not say that because I didn't take Monday to Friday, Saturday, I'll take my balance. No, Saturday is your 1 beer. Treatment of hypertension. The idea nowadays is we go combination. Usually start patients as much as possible, start them on 2 drugs. In the African population, the best drug to use is a calcium channel blocker. So whatever else you don't remember from this talk, please remember, start the patient either on amlodipine or nifedipine. Whichever calcium channel blocker you have available, start the patient on that one. You can add either HCTZ, or you can add clothalidone, or you can add losartan or any ARB or ACE inhibitor you have. So you can use either enalapril, captopril, you can use losartan, you can use amlodipine or nifedipine, but you must have amlodipine or nifedipine on board. And then you add HCTZ. Then you check if the patient is controlled, i.e. the blood pressure has settled down to less than 130/90. If not, then you add the other drug. So just start with your CCB, nifedipine, amlodipine. Check the blood pressure. If not controlled, add a diuretic or an ACE inhibitor. If not controlled, then add the 3rd drug, that is whether the ACE or the diuretic. And finally, in step 3, the patient is not controlled despite being on either an ACE inhibitor with an ARB, CCB, and diuretic. We call that resistant hypertension, and you can start the patient on spironolactone or an alpha blocker. Alpha blockers are like prazosin. Beta blockers are like atenolol, carvedilol, metoprolol, nebivolol, any of those. But the idea is always have these first three on board before you go to this last one. Is that clear? Are you guys able to talk? Okay.
Yeah, we've muted because they
Oh,
are many.
all right.
They are good.
So
They are
simply,
following. Yeah.
see the patient, blood pressure, add nifedipine, amlodipine. Blood pressure not controlled, add HCTZ. Blood pressure not controlled, add losartan or enalapril. Blood pressure not controlled, send the patient for a specialist review, we add spironolactone. How do we monitor? Ideally, our target is to get the blood pressure below 130/80. But I want to give you a caveat to that. For elderly patients, these are patients above the age of 85, we loosen the target a bit. We just say get them below 140/90. Patients with chronic kidney disease, those ones, it's very difficult to get them to 130/80. So for them, we also just target below 140/90. And you should actually monitor these patients ideally every month or every 3 months, depending on the patient. So your elderly patients, your CKD patients, your patients with other conditions like heart failure, you may want to see them every month initially, and then every 3 months once they're stable. But for patients who are otherwise stable, have no other complications, those are patients you can see comfortably within 3 months. The whole idea is get that target blood pressure within the 3 months of diagnosis. That is our target. So when I tell you about adding medication, you can actually add it every month. So you start off with amlodipine, nifedipine. You see the patient in a month's time, blood pressure not controlled, add the other drug. However, if this is a patient with complications, heart failure, a patient has CKD, a patient is pregnant, don't wait a month. Those are patients you see within a week. Okay. So what are the hypertensive crises? These are basically the emergencies we are talking about. We have two. There's a hypertensive emergency and the urgency. The difference between these is simply this. Is the emergency, so a patient comes in, blood pressure is high, and they have a stroke. That's an emergency. Blood pressure is high, the patient has a heart attack. That's an emergency. Blood pressure is high and the creatinines are suddenly elevated. You saw this patient a month ago, they had normal creatinines. Today, they are 300 and above. That's an emergency. Those are patients you send directly to ICU, HDU to control. Or the patient has come in, blood pressure is high, and suddenly they're not able to see. That's a patient you send immediately to ICU for BP control. Urgencies are these patients whose blood pressures are elevated, but there's no acute damage. So huyu ni mgonjwa ambaye anakuja, you check blood pressure is 220/120, but they have no symptoms. There's no headache, there's no vomiting, there's no chest pain, they're not having difficulty breathing, they are perfectly fine. These are patients you treat as urgencies, meaning you can start them off on treatment, but you don't have to admit them to HDU. So what are the emergencies? These 5 I've told you. In the brain, you're looking for a stroke or the patient is acutely confused. In the arteries, you're looking for acute aortic syndrome. So those are basically patients with aortic dissection. How patients aortic dissection present is either they're in shock or they tell you, I got a sudden chest pain, like something is tearing in my chest, and the patient fainted. That is most likely an acute dissection with elevated blood pressure. Of course, pregnancy-related hypertension, those ones we don't even joke about them, send that patient to HDU. Retinopathy is a patient who tells you suddenly they can't see and their blood pressure is elevated. And they didn't take alcohol, they didn't take methanol, this kumi, they didn't take that. This patient just got a headache, blood vision, unable to see, blood pressure elevated, send that patient to ICU for control. Kidney disease, we are looking for those patients who suddenly the creatinines have gone up or the patient suddenly develops flash pulmonary edema or suddenly they're having difficulty, they're not able to pass urine. Those are patients you send immediately to ICU for control of the blood pressure. In the heart, we're looking at heart attacks. So patient has chest pain or the patient has very low blood pressure or this patient is severely congested in the chest. Those are hypertensive emergencies and we need to send them for IV rapid BP control. So the rate of rise above baseline is important. You notice I said previously that we define the emergency by how the patient presents. It's not so much the BP value. Of course, if the systolic BP is above 180 and diastolic is above 120, those are patients you might consider putting in hospital for purposes of controlling that blood pressure. But the definite emergency is that patient who, regardless of the blood pressure, And when I say regardless of the blood pressure, I mean even the patient whose blood pressure is 130/70, but this patient has sudden loss of eyesight, has chest pain, has difficulty breathing, is edematous, is pulmonary congestion, has a stroke, or has fainted. These are emergencies. Regardless of the blood pressure, send that patient to ICU. And so how do we manage these patients? For the urgent patients, these are the patients whom I said the blood pressure is high, but the patient has no symptoms. They're walking around okay. That one you can either put them in the ward, give them oral medication, but if the patient is somebody whom you know is nearby, can follow instructions, can understand when they're going to go into an emergency state, you can manage them as an outpatient and tell them, here, start on these medications, come back in 2 days' time or in a day's time, I see how you're doing, and you follow them up more closely. The emergency, just admit that patient to HDU or ICU. And what do we do? Hypertensive encephalopathy, patient with headache, confusion, blurred vision, vomiting, features of raised intracranial pressure. Reduce that blood pressure by 20 to 25%. IV labetalol is your drug of choice. Patient with comes in, they have a stroke, systolic BP is above 220, diastolic above 120. Reduce that blood pressure within an hour. IV labetalol is a drug of choice for that one. Patient who you think requires thrombolysis. Okay, this one I'm just giving you for purposes of information, but thrombolysis, we only do it in very high level centers because for patients with stroke, you can only give the thrombolysis within 3 hours of onset of symptoms, not of showing up in hospital, of the patient telling you, I got weak. So if the patient got weak in the morning and they show up in the hospital in the evening, they're no longer a thrombolysis patient. These patients, again, IV labetalol is a choice to use. Acute hemorrhagic stroke, so patient comes in with stroke, you do a CT scan and it shows you bleed, that IV labetalol, and you need to immediately reduce that pressure to below a systolic of below 130. Immediately, so IV labetalol is a drug of choice. Acute coronary syndrome, so these are patients with MIs, chest pain, difficulty breathing, immediate. You need to reduce the blood pressure to below 140. IV nitroglycerin is first choice. If not, we use labetalol. You notice I keep talking about labetalol because it's a drug I know that we can find here more commonly. Patient with acute cardiogenic pulmonary edema. So these are patients whose blood pressure is elevated. They're in congestion. So they are pulmonary congested. You need to intubate this patient. Reduce the blood pressure immediately. Best drug of choice, furosemide or nitroglycerin with an IV loop diuretic. So you give this patient IV nitroglycerin and IV NTG as an infusion and give them IV Lasix to reduce the edema and to actually reduce the patient's congestion. Patients with an acute aortic disease, those are patients with aortic dissection. So these are patients whom you've done the X-ray, you see a very widened mediastinum, the echo tells you that there's a dissection. Please reduce that blood pressure with immediate effect with IV labetalol. In fact, these patients, you need to target a heart rate of less than 60. So you need to give these patients drugs to reduce that heart rate. So beta blockers are the best way to go. Patients with eclampsia, we use IV labetalol or magnesium sulfate. Malignant hypertension, these are patients in whom you find that they've suddenly gotten elevated creatinines and the patient is going into acute renal failure. You reduce with labetalol. And that is the end of my presentation. Thank you. Any questions?
Yes, thank you, Doc. I'll go faster to the questions. Okay. So we have several questions, but I know because of time I'll not be able to share all of them at once. So the first question that we'll look at is, let me pick this one. Let's see.
People are not heard.
No, there are several questions here. Okay, so the first one is the question on hydralazine. asking after how long do you add second drug or the third drug?
Okay. For those patients with elevated blood pressure above 160 over 100, so systolic is above 160, diastolic above 100, those ones you immediately start them on 2 drugs. So 2 drugs means you give them nifedipine with either losartan or nifedipine with HCTZ. Those ones are immediate. The patients in whom you're going to take stepwise. So generally, all patients, the ones between 140 to 160, 90 to 100, those ones you can start with 1 drug, say nifedipine 20 BD. And then after that, you tell the patient, come back in 2 weeks' time, we see how your blood pressure is. And then you gradually escalate the dose, or you can add another drug. But in most cases, you find that you'll actually have to use at least 2 drugs for most of these patients. I hope that is clear.
Is hydralazine an option for resistant high blood pressure, hypertension?
You can use hydralazine for those patients in whom spironolactone can't be used. And the patients whom we don't use spironolactone are those ones who have a problem with their potassium. So usually patients with kidney disease, renal failure, we can't use spironolactone. So for them, we use hydralazine.
Comment on pregnancy-induced hypertension, current management, when and how to wean off medication.
Pregnancy-induced hypertension, normally these are patients whom you start on calcium channel blockers. And then for them, you actually target a blood pressure of less than 130 over 80. Yeah? So you're targeting more like around 120 over 70. And these patients, the next drug, if the nifedipine doesn't control, you can actually add methyl dopa. If that doesn't control, you actually have leeway to use beta blockers like nebivolol. And if those ones don't control, then after that, you actually use hydralazine. When you decide that this patient, we are going to end up weaning off, no, what you do is that you monitor the blood pressure throughout the pregnancy. Once a patient delivers, some patients, the blood pressure just goes down to normal. In fact, they got hypertension, so you have to remove the drugs. But what you do is that at least for 6 weeks after delivery, you have to monitor that patient very carefully to see whether or not the blood pressure settles. And you don't just remove all the drugs, you remove them pole. So for example, the patient was on 4 drugs, they've delivered. 1 week post-delivery, you find the pressure has come down to say 130 over 80. You can say, I'll remove the hydralazine, I see what is happening. Then in a week's time, you check. If the blood pressure has been holding steady, you tell them, let's wait like that until 6 weeks. Then after that, we continue monitoring your blood pressure. So these are patients whom you can see frequently every 1 month or so. And then you decide about weaning.
Wow, Doc, there's several questions, close to 150. I don't know. I'll just sample. I know. Hello, Doc. I have a client. She uses comicadis, so 40 mg, but her BP is always 140 over 75, and not reducing. What can I advise her?
Add amlodipine, 5 milligrams.
Okay. Is there a need to aggressively reduce BP in HTN urgency? Can we use IV labetalol or oral antihypertensives?
No, for hypertensive urgencies, these are just patients whose blood pressures are elevated, but the patient does not have any acute emergencies. Like I said, stroke, heart attack, pulmonary edema, worsening renal functions. These ones you can actually use medication. I strongly advocate we should not use sublingual nifedipine. Do not use sublingual nifedipine. Absolutely not. If you feel the patient needs to be admitted, admit the patient and either use IV labetalol or give them oral meds, but don't give sublingual nifedipine.
Okay. What will cause hypotension in hypertensive 85-year-old on nifedipine 20 milligrams BD?
Hypotension in elderly patients, number one, you need to check rehydration because unfortunately old people, the thirst center sort of ages, so they don't drink as much fluid. So you have to be very keen on that. So if your patient is hypotensive and they're elderly, the first thing you need to do, withdraw the hypertensive drugs first. And then check on hydration status. Check for infection because infection can cause low blood pressure in elderly people. Check for a sudden deterioration in cardiac function. So do an echo to rule out either a heart failure or to rule out a stroke, because those are the things that cause hypotension in old people. But the commonest actually is dehydration. So check your patient's hydration status, hydration and sepsis, and then you can check for cardiac conditions.
Okay.
But withdraw the blood pressure medications because hypotension is very dangerous in old people.
All right. In level 4 centers where IV labetalol isn't available, which drug would you recommend for hypertensive emergency? A high dose of oral sublingual nifedipine or IV hydralazine?
IV hydralazine. Please do not use sublingual nifedipine. Do not use sublingual nifedipine.
Okay. Is there a situation one can stop the medication? Does lifestyle alone manage the hypertension? That's first common question.
Lifestyle usually manages patients in what we call high normal blood pressure. So these are patients whose blood pressures are maybe about 130 to 140. The patients you don't really want to start on medication. Those ones you can actually tell them modify your lifestyle. With regard to patients above that, say they're stage 1, 140 to 159 style. But what I found is that they tend to increase their exercise, to reach their weight. You may find that you can actually control the blood pressure, but they have to maintain that lifestyle. It's not a one-shot bullet.
Allow me to take 2 more.
Yeah.
10 minutes. What is the role of atorvastatin in hypertensive patients? Can it be given prophylactically? Does it have any benefit with the patients with normal cholesterol levels?
So what we do for patients with hypertension is that's why I wrote there, we need to screen them for cholesterol. The role of atorvastatin is basically for control of secondary risk factors like the cholesterol, and we give targets to these patients. So if you do the patient's lipid profile and you find that the patient has an LDL level above 4, for sure you need to start that patient on diet plus atorvastatin or any statin you may have available. The idea is basically to reduce atherosclerotic disease, which can put the patient at risk of stroke and heart attacks and peripheral arterial disease. So all your hypertensive patients, regardless of age, please screen them for cholesterol.
Doc, this is the last one. You can see the questions are so many, over 200. I think we can stay a whole day here. This is the last one. For those with hemorrhagic stroke, do you reduce blood pressure or you withhold drugs for 24 to 72 hours? Considering effect of cerebral perfusion pressure, what is the evidence based on this?
Okay. That's a good question. So if you can see from the slide, can we go back?
Yeah.
I indicated that your patient with hemorrhagic stroke, your patient with an acute hemorrhagic stroke whose systolic blood pressure is 180, you need to reduce that systolic blood pressure to 130. The best drug to use is IV labetalol. The whole idea is that basically the hemorrhage, you need to reduce this, to reduce the speed. The pressure is driving hemorrhage and it's going to increase the amount of hemorrhage. So once you get there, there's a drug, but it's a drug that you can use also gently brings down the blood pressure. It's something you can actually control. You see, sublingual nifedipine, the reason why we fight with is because it's unpredictable. It can cause a sudden drop in blood pressure and the patient gets cerebral ischemia. So something you cannot control, you do not use. But IV labetalol, you can actually titrate because you're using very low doses, 1 milligram per minute, and you actually monitor continuously with this blood pressure.
Wow, Doc, thank you.
There's a question about pregnancy-induced hypertension.
Yes, yes.
CCBs are the first-line therapy. Nifedipine is first-line therapy in pregnancy-induced hypertension. Methyl dopa is another drug you can use. Hydralazine is another drug you can use. Another drug you can use to control the blood pressure is beta blockers, maybe nebivolol. However, you notice I put the beta blocker at number 4. Start with the calcium channel blocker, use methyl dopa, use hydralazine. In these patients, you must absolutely avoid, it's absolutely contraindicated. Do not use an ACE inhibitor or ARB. So don't use enalapril, losartan, telmisartan, any of those pregnant women, because you're going to end up with fetal renal agenesis. So the fetus does not develop the kidneys. Do not use spironolactone because it actually interferes with development of the sex hormones. Kindly. avoid spironolactone, avoid ACE inhibitors and ARBs in any pregnant woman.
Perfect. I think, Doc, that is the end.
Maybe what we can do is just do this thing on a 6-weekly basis.
Yes, because the questions are crazy. Even last time we had a total of almost 250. Today we are also doing almost 270. So
so my suggestion is maybe what we do
yes
is the next one we organize, we now just answer questions.
Yeah, we'll pick up the questions, then we just do question and answer session for this. Otherwise, thank you, Doc. I know you are busy today with several activities. I thank you for the time and allow me to release you.
Thank you.
And much appreciative. So,
no sublingual nifedipine.
Thank you. That is the closing remark. No sublingual nifedipine for that. And I want to say thank you, team. I know some of you are disappointed for me not be able to. Definitely, yes. I think we'll work with the medical research team to really have a question and answer session on this issue of hypertension, because like this is the craziest webinar. We have our attendance of over 1,600 attendees and over 300 questions to be pertaining this. So I think it is one of the topics that we need to revisit now and again. Thank you very much. From my side, I want to say thank you for the attendance, for the questions and participation. We'll be able to have the next session and we'll be able to notify you in your respective email addresses. Otherwise, for the issues CPD points, that is what we are projecting now. So you can see how to get your CPD for this webinar. Otherwise, I want to say thank you, team, for the joining. And as we've promised, this is the second time we are repeating this topic, and we will not tire from continuing. And kindly refer your patient as soon as possible. Mwai Kibaki Hospital is really ready to receive your patients. We are ready to see them on the best and give them the best care possible. We have a team of A&D specialists, team of ICU specialists, consultant. You can see one of our consultants, the work is doing. So you really need to bring those patients to our facility. We'll be able to manage your patient well, kindly. And we are even ready. Our numbers are open for you to contact us anytime at our accident and emergency. So you'll be able to reach out to us and call and just tell us that you needed to refer your patient. So maybe I can first go through, give you our numbers. So our accident and emergency number. So you'll be able to call and inquire for referral of your patients. We'll be able to give the best care for your patients all over Kenya, not only in the central region, but all over Kenya. We'll be able to do that. Just a quick one, I give you our accident and emergency number, so you can call and do referrals for your patients with different conditions. All right, so here are our numbers. You can reach us out through the following: 011 059 7669. That is one number you can call, and you'll be picked by our accident and emergency team for any referral inquiries. Alternatively, you can also reach us through this number, which is 0782 620 353. 0782 620 353. These are our 24-hour numbers. Just call, inquire for referrals. Our team on the ground will be able to support you for any referral, for any inquiry, even consultation. Thank you very much from my end. We'll have a repeat of this and a question and answer session. We've compiled all your questions. We'll be able to answer them. Until next time, have a lovely evening, a lovely day.